In this section, we are going to discuss on the marrow failure syndromes. Typically, the most important emphasis will be on the bone marrow failure and the aplastic anemia. But it's also important to understand some congenital marrow failure syndromes, which is also important for exams. So first, bone marrow failure syndromes, we have to know about the etiology. Etiology wise, if you ask me, I can split into three. One is the aplastic anemia group. Second one, I can put something called others, and third one I can put into something called congenital bone marrow failure syndrome group. So these are the three things that are very important. Aplastic anemia, it is generally an autoimmune disease. It is due to autoimmune destruction of the hematopoietic stem cell by CD8 positive lymphocytes. So this is the genesis of aplastic anemia. But let us finish off the other things. First, let me finish off the etiology, then I'll explain only certain few important things in detail. So when you move about the other causes wise, the first one you can get with stem cell destruction due to radiotherapy or chemotherapy or certain chemicals like benzene and all these things. Radiation therapy is a well-known thing, very important. And chemotherapy also, like many chemotherapeutic agents like alkylating agents, including cyclophosphamide, busulfan, lot of chemotherapy drugs can result in significant bone marrow suppression and complete, like pancytopenia. All these things are possible. And chemical probably, like exam wise, it is important is the benzene. Chemical wise, you can think about benzene, then certain OPC drugs, organophosphorus compounds, then you can get with DDT, pesticides, all come under OPC anyway. So these are the things that typically produce. At the same time, it could be something called idiosyncratic drug reactions. Typically in exam, they will ask you about this chloramphenicol NSAIDs predominantly most important for exam purposes is chloramphenicol. It can happen with many drugs, antithyroid drugs, very, very important. Your antithyroid drugs, agranulocyte is one of the very important complications. It can happen with even your NSAIDs, sulfur drugs. A lot of things can result in idiosyncratic drug reaction and bone marrow failure. So very important, think about the radiotherapy, then think about the chemotherapy. Any chemotherapy drug used in cancer can result, especially alkylating agents. You can result with certain chemicals like benzene, DDT, OPC, pesticides and all. Then you can get with some idiosyncratic drug reactions, especially chloramphenicol is an exam favorite. It can happen with NSAIDs, sulfur drugs, then it can happen with even antithyroid drugs as well. So colchicine also. So a lot of drugs can produce idiosyncratic drug reactions and agranulocytosis and bone marrow failure. So next thing you can get is with a lot of viruses. Viruses can produce. For example, you can get with HHV6, HIV, Epstein-Barr virus, parvovirus B19. All these things can result in bone marrow failure. But apart from that, one important group is there. This is post-viral hepatic failure. There is something called post-viral hepatic failure. It's a very common entity. Not given in many textbooks. It's called post-viral hepatic failure. But remember, the moment you think about this post-viral hepatic failure means you think about hepatitis viruses like AB. No, it is not due to hepatitis A, B, C virus. Very important. It's never due to hepatitis A, B and C, the common virus, what you know. This hepatic failure is due to probably maybe even due to Epstein-Barr virus or cytomegalovirus. You don't know. But some viruses apart from your A, B, C, hepatitis A, B and C, if they are going to cause hepatic failure, that's called post-viral hepatic failure, they can result in profound bone marrow suppression and pancytopenia. Very important fact. So a lot of viruses can cause. And number 3, you can also get with immune disorders. A lot of immunological disorders like systemic lupus erythematosus, graft versus host disease. Then after hematopoietic stem cell transplant where you don't have recovery because of the allogenic transplant, you might get this immune reaction destruction of hematopoietic cells, and you might get with even thymoma. All these are immune related causes. Number 4, you have to know about the PNH. Very, very important, because PNH per se has an overlap with aplastic anemia, and aplastic anemia itself, many patients will have PNH clones with them. So I told you there is a lot of overlap between aplastic anemia and PNH. So don't forget the PNH as an important cause of aplastic anemia. So these are some of the other causes that you have now. One is the stem cell destruction due to radiotherapy, chemotherapy, or chemotherapeutic drugs, or some chemicals or idiosyncratic drug reactions. Then you might get with your immune mediated disorders, paroxysmal nocturnal hemoglobinuria, and you might also get with a lot of viruses, but very important is the post-viral hepatic failure, which is not due to the hepatitis A, B and C. Congenital cause, if you want to divide, I will divide into two. One is called the Fanconi anemia, and second one is non-Fanconi bone marrow failure. So Fanconi anemia or Fanconi related bone marrow failure is a separate thing which we'll discuss in some time. At the same time, non-Fanconi related bone marrow failure typically is due to 3 reasons. One is called SBS, that's called one is called DBA, that's called diamond blackfan anemia, and second one is you have something called SDS, that's called Shwachman-Diamond syndrome, which we'll discuss again, and third one you have something called dyskeratosis, X-linked dyskeratosis congenita, other is called as X-linked DC. So I can write DBA as something called diamond blackfan anemia, then SDS I can write as something called Shwachman-Diamond syndrome. Sorry for the spelling if I'm wrong. So that's called Shwachman-Diamond syndrome. And third one is something called X-linked dyskeratosis congenita. So these are the 3 marrow failure syndromes that are grouped under non-Fanconi related bone marrow failure. So Fanconi related bone marrow failure and non-Fanconi related bone marrow failure. And comes the king of all, that is the aplastic anemia group. So let us discuss in detail on what is aplastic anemia. The moment if you call about aplastic anemia, it has to be idiopathic. Usually it is idiopathic almost 1/3 to 2/3 of the cases. This aplastic anemia that is idiopathic contributes to 1/3 of the 2/3 of the cases of marrow failure. So it's typically idiopathic in nature. It doesn't have any cause usually. So second thing is usually it's an acquired entity, it's not something congenital, very important, because we have a lot of congenital marrow failure syndrome that is grouped under separate disorders. It should not be called as an aplastic anemia, it is something that is acquired. If they ask you most common cause of marrow failure syndrome, and again answer is aplastic anemia only. Aplastic anemia is the most common cause of marrow failure in the world. So pancytopenia and marrow failure. So acquired cause, it's an acquired thing. The next thing, if you want to know what is the reason pathophysiology wise, if you ask me, it is due to autoimmune destruction. Autoimmune destruction, what they are going to destroy? Hematopoietic stem cell, the pluripotent hematopoietic stem cell in the bone marrow, that is what is going to be destroyed by CD8 positive T cells, CD8 T lymphocytes, cytotoxic T killer cells. These are the ones that are going to destroy these hematopoietic stem cells within the bone marrow due to unknown reason, we don't know the cause. So next thing, is there any mutations that are present? There are 2 types of mutations are there. One is the PIGA, ASLX1, and you have DNMT3 complex, DNMT3A, and the third one, the telomere repair complex. Telomere repair complex. So certain areas mutations will not be seen at all, so no known mutations will be there, but still. So this group is the most common, accounting to almost 60% of the mutations seen in aplastic anemia. PIGA gene, and you have something called ASLX1, and you have DNMT3A, that's called your DNA methylases, those enzymes. So DNMT3A. Remember, this PIGA gene is also associated with, you know very well, it is PNH, and this ASLX31 and DNMT3A is also associated with myelodysplastic syndromes. That is the reason whenever you see an aplastic anemia, whenever you have these gene mutations, it is very, very important to rule out PNH, as well as there is an entity called hypoplastic MDS, which I will discuss in MDS. MDS generally tends to be hyperplastic, bone marrow tends to be hyperplastic in MDS, but there is an entity called hypoplastic MDS. So it's very, very important to rule out hypoplastic MDS also in a patient who is having suspected aplastic anemia. So any patient suspected aplastic anemia, 2 most important disorders to rule out is PNH and hypoplastic. myelodysplastic syndrome, because the same mutations can be seen in the respective disorders also what is seen in aplastic anemia. That's why it is very important. So these are the mutations that is very, very important. Then next thing, what will be the clinical features? Clinical features, typically it is due to the pancytopenia. So pancytopenia, usually anemia will cause in fatigue, cardiac failure and all these things. Leukopenia will predispose to infection. Thrombocytopenia obviously is going to predispose to the bleeding manifestations. Then that is very well known fact. I'm not going to discuss in detail. But second thing, that is what is more important, that is called there is no hepatosplenomegaly and there is no lymphadenopathy. Very, very, very gold standard point. Presence of hepatosplenomegaly and lymphadenopathy rules out your aplastic anemia as a cause of pancytopenia. Not possible. There are two things you can rule out if there is hepatosplenomegaly. One is your immune thrombocytopenic purpura, that is ITP, and second one is that's primary ITP. I'm not talking about secondary ITP. Primary immune thrombocytopenic purpura. Definitely ruled out. Idiopathic. Not possible in the presence of hepatosplenomegaly. Similarly, aplastic anemia is impossible in the presence of hepatosplenomegaly and lymphadenopathy. So you can rule out. That's a very important point to be noted. And diagnosis wise, if you ask me, the patient will have pancytopenia in the peripheral smear, and they will have reduced reticulocyte count, which means indicating the bone marrow production itself is lost. At the same time, the patient will have a hypocellular marrow. Hypocellular marrow. Patient will have a hypocellular marrow, that is the bone marrow will be the cellular component of the bone marrow will replace with fatty tissue, which means the the marrow will no longer be cellular, it will be more of a fatty component. The fatty component will keep increasing and only fatty tissue will be seen in the marrow. You won't see any cellular marrow. So this is what we call hypocellular marrow. At the same time, patients may have MCV may be normal or even increased, very important point. Patient may have one of the important cause of non-megaloblastic macrocytosis. So MCV may be normal or even increased, but definitely not low. And so you might be needing to do flow cytometry. If they ask you why in an aplastic anemia you need a flow cytometry, you need a flow cytometry in aplastic anemia to rule out two things. One is PNH, probably MDS, and third thing is you might be needing to rule out congenital cause of aplastic anemia. Bone marrow failure. So that is the reason why you do flow cytometry. Apart from that, flow cytometry is not diagnostic of aplastic anemia, but it is rule out other possibilities like especially PNH. That's what is the key for exam. So I already told you, flow cytometry is a gold standard for diagnosing PNH. If you have any doubts, you can go and look back on the PNH chapter, which I have discussed in great detail on that. Then, so what will be the treatment? So we have diagnosed the aplastic anemia. And treatment of aplastic anemia, if they ask you, the best treatment is allogenic stem cell transplant. So it's having very good success rate, 80% success rate with 80% 5-year survival. Very good. Allogenic hematopoietic stem cell transplant. Very, very important. After allogenic stem cell transplant, because many people will not be the candidates or allogenic stem cell transplant will not be available for many people, in those scenarios, alternative to allogenic stem cell transplant, you can provide immunosuppression for these patients because it is due to autoimmune mediated destruction of hematopoietic stem cell by CD8 cells. So you have to give immunosuppression. So what kind of immunosuppression you give? You will be giving calcineurin inhibitor plus I'll be adding one anti-thymocyte globulin. You know what is the calcineurin inhibitor? It is going to be either a cyclosporin or a tacrolimus, any one, plus anti-thymocyte globulin ATG I'm going to add. ATG will be two types. One is called a horse ATG or a rabbit anti-thymocyte globulin. In this, best is horse ATG, which is one of the recent studies in NEGM which is clearly proved that horse ATG is much better than rabbit ATG and it increases the survival, and this is what we currently follow. When I was working in the hematology unit, this is what I tend to follow, the horse ATG one. That's what we follow right now. So calcineurin inhibitors with the anti-thymocyte globulin, that's what we do it. So immunosuppression. So very important. At the same time, along with the immunosuppression alone will not be enough. They might be needing some stimulants of the marrow. So for example, the one stimulant that is very important is TPO mimetic. TPO mimetic like L-Trombopag. L-Trombopag, this is definitely known to improve survival. The other bone marrow stimulants are not that beneficial, but still you can give erythroid stimulating agents. Erythroid stimulating agents are indicated, standard indication if serum erythropoietin is less than 500 plus you have low RBC count, then you can give ESA in many cases, not only for this case. So ESA, erythroid-stimulating agents like epoetin alpha, darbepoetin, then you can give pegylated methoxy, pegylated epoetin beta, all these things you can try. So anyway, erythroid-stimulating agents. Then you can give GCSF, like filgrastim and all. So GCSF is also indicated, because this GCSF can increase the neutrophil count and they can reduce the risk of infections. Apart from that, the only important thing that ideally is not important for entrance exam point of view, but really if you want to know pure knowledge, then one thing that you might be needing to know is this TPO-mimetic is the only thing that probably improves a bit of survival by decreasing the bleeding manifestations. Apart from the other things are not that important. At the same time, the patients may also, you can add supportive transfusions if the anemia is very severe. In those conditions, they might need transfusions, plus or minus you need antibiotics for probably infectious reasons. So you might need extra antibiotics. But more important you have to know is the allogenic stem cell transplant versus immunosuppression. Remember, if you take old textbooks and see, they would have given androgens. Androgens are currently not the norm, because androgens are completely outdated right now. At the same time, they have very, very high side effect rate. So what are the side effects of androgens? They can produce cholestatic jaundice, they can produce virilization. At the same time, this androgen use for a longer time may increase the risk of hepatocellular cancer also. At the same time, they are also going to have very poor survival benefit, and their effect is also not very conclusive. That's the reason why currently we don't use that much of androgens, because of the significant side effect. At the same time, they're outdated because the effect is also not that great compared to the allogenic stem cell transplant or versus your immunosuppressive therapy. So this is what you have to do in a patient with an aplastic anemia. So that's what we're going to do. Apart from the other causes we saw already, but very importantly, we didn't see about the congenital causes, Fanconi's anemia. So the most important is the Fanconi anemia. That's what we're going to discuss first. Whenever you think about Fanconi anemia, mutation wise, if you see, almost 15 genes are involved. Different sets of genes are there. This is called Fanconi, FANC, Fanconi disease genes from 1 till 16 is there. So, but only 15 genes are there. Don't think like 1 to 15, somebody in between one letter might be missing, but I really don't know. But still, so 1 to 16 genes are there. I mean, almost 15 genes are there that can result in Fanconi disease and Fanconi anemia. And second thing, what is the pathophysiology is because of increased spontaneous chromosomal breakage. The problem in Fanconi anemia is very high levels of spontaneous breakage of chromosomes. The mutations in Fanconi anemia will lead to high levels of spontaneous breakages in the chromosomes. That's what we are going to, the principle that we are going to utilize later while diagnosing Fanconi anemia. We use something called DEB test, which I will tell you in some time. So increased risk of spontaneous breakage of chromosomes. And the next thing, what is very important, is the clinical features. The clinical features, what you will see in this patient is obviously bone marrow failure, and hence you might be resulting in something called a pancytopenia. Typically they have macrocytic pancytopenic anemia. And next one, the patient will have multiple physical abnormalities. The most important physical abnormalities that they are going to ask in exam consistently is the absent radius and the thumb. Absent radius and the thumb. So this is a very important and consistent physical abnormality that they will ask you in Fanconi anemia. Apart from that, patient may have stunted growth or growth retardation. Patient may have hypo or hyperpigmentation. Hypo or hyperpigmentation. Patient may have Caffiole spots, Caffiole macules. Patient may have learning disability, and patient may have horseshoe kidney, and patient may have even a microcephaly. Patient may even have a microcephaly. So these are things, but if you ask me what among all these things is very important, this absent radius and thumb is the top most important thing. That is the most important that you have to know. And second, probably this horseshoe kidney probably might be our second most important. Apart from that, other things you may or may not know, but that doesn't really matter a lot in Fanconi anemia. These two physical abnormalities are very important. Apart from this physical abnormality, this Fanconi anemia also predisposes to a lot of cancers. Typically it can be hematological as well as it can be solid organ tumors. Hematological cancer that it predisposes is very importantly, one is the AML and second is myelodysplastic syndrome, and solid organ tumor that it predisposes the squamous cell cancer of the neck, of the head and neck. Squamous cell cancer of the head and neck. So these are some of the solid organ malignancies that are predisposed by hematological cancer. So remember these three. Whenever you think about Fanconi anemia, one is pancytopenia, second is physical abnormalities, and third is predisposition to cancer. So these are three things that you have to note about the Fanconi anemia. And very importantly, the most important physical abnormality that I generally told you about Fanconi anemia is the absent radius in the thumb and the horseshoe kidney. That's very, very common in exam, especially the absent radius in the thumb. And next thing, how will you diagnose? Diagnosis of Fanconi anemia. Typically, one test they will ask you in exam, that is called a DEB test. DEB stands for something called diepoxybutane. DEB stands for something called diepoxybutane. So what happens is, whenever you put this diepoxybutane and incubate the lymphocytes that are obtained from the peripheral smear, not from the marrow. Very important point again. This is also one of the old AIMS questions. So where you obtain the lymphocytes from the peripheral blood and you incubate with this diepoxybutane, and later on you analyze by karyotyping, you will have very high levels of chromosomal breakages. So this is what is called DEB test, and this confirms the presence of Fanconi anemia in the patient with appropriate clinical features. They ask you treatment. Treatment is very simple. You are only going to go for something called allogenic hematopoietic stem cell transplant, and this is the only thing that is curative in case of Fanconi. Apart from that, it is not curative. But the money is also on the non-Fanconi anemias. There are three non-Fanconi anemias I told you. One is Diamond Blackfan, Schwachman Diamond, and disc keratosis congenita. But the problem with this non-Fanconi related bone marrow failure syndromes is one thing that is very important for exams. These are all due to problems in the ribosomal protein biogenesis. These are all is due to problems in ribosomal proteins. Because they are due to problems in the ribosomal proteins, they are also called as ribosomopathies. This is a new terminology given to all these things. They are generally due to problems in the ribosomal protein biogenesis. That is why they are also referred to as something called ribosomopathies. So let us see a short distinction between these three disorders. One is called the Diamond-Blackfan anemia. Second one is the Schwachman-Diamond syndrome, and the third one is the X-linked disc keratosis congenita. So what will be the features? The first one, all will be due to ribosomal protein biogenesis only, but what will be the mutations? Mutations, what you are going to see is the RPS19 here. That's the most important mutation, plus lot of other mutations are there, but the most important that they are going to ask in exam about Diamond-Blackfan anemia is the RPS19. That's a ribosomal protein mutation. SDS, the mutation is something going to be SBDS. That is a protein that is mutated here. That's called SBDS protein. Then for disc keratosis congenita, you have something called diskerin mutation, which is given by a gene called DKC1, or you can also get in something called TERK gene that is related to telomeres. So TERK gene or DKC1, diskerin gene. So these are the two genes that you have to remember, and SBDS gene for Schwachman-Diamond syndrome. So these are the things. So what is the effect? Effect of these mutations must be on the ribosomes. Already I told you all these three things are ribosomopathies. So effect will be impaired 40S and 60S ribosomal proteins. Impaired biogenesis of 40S and 60S ribosomal proteins. Here it is impaired maturation of 60S. It is not impaired biogenesis. That is impaired biogenesis number one. That is your Diamond-Blackfan anemia. In Schwachman-Diamond syndrome, it is due to impaired maturation of 60S ribosome. Here In disc keratosis congenita, it is due to impaired post-transcriptional modification of ribosomal RNA. So this is the problem in disc keratosis congenita. So these are the three things that are important. All are ribosomopathies. That again I'm telling you that point. And next thing, what are the bone marrow failure? What are the effect on the bone marrow? So here typically you will get in red cell aplasia, that is you will get macrocytic anemia. That's the only thing that you will get in a Diamond-Blackfan anemia. In Shwachman-Diamond syndrome, the most important is the neutropenia. That's what is the most important. Disc keratosis congenita, the most important is the anemia and thrombocytopenia. Anemia and thrombocytopenia. So that's what you are going to get in disc keratosis congenita. But here only anemia. In SDS it is neutropenia, and in disc keratosis congenita it is anemia and thrombocytopenia. So there are a lot of other effects are there. If you ask me other effects, number one, you have physical effects like Fanconi anemia. What are the physical effects you are going to get? Physical effects, what you are going to get is short stature. Patient will be short and the patient will be having craniofacial defects. At the same time, patient may also have thumb-related abnormalities. So short stature, craniofacial defects and thumb-related abnormalities. And in Shwachman-Diamond syndrome, patient will have exocrine pancreatic insufficiency. And the patients might be suffering from long-term steatorrhea, and because of that itself, patient's growth may be retarded and the patients may look short. So exocrine pancreatic insufficiency, very, very important point. This exocrine, how this absent radius and thumb is important for Fanconi anemia. Similarly, this exocrine pancreatic insufficiency is very, very important for Shwachman-Diamond syndrome, SDS. So here the patient will have a triad of physical abnormalities. One is nail dystrophy, and the patient will have skin hyperpigmentation, increased skin pigmentation, that is called skin hyperpigmentation, and the patient will have mucosal leukoplakia. So all these things, this is a characteristic triad actually. This triad is also very important for exams. Nail dystrophy, leukoplakia, and increased skin pigmentation or hyperpigmentation of the skin. Apart from the physical abnormalities, what are the hematological cancers? Like Fanconi anemia, you have a hematological association with hematological cancers. Diamond-Blackfan anemia is associated with MDS, and disc keratosis congenita is associated with AML, and Shwachman-Diamond syndrome is associated with both MDS as well as AML. So very important. At the same time, they are also associated with solid organ tumors or solid organ cancers. Very important solid organ tumor that is associated with Diamond-Blackfan anemia is osteosarcoma and other soft tissue sarcomas. Osteosarcomas and soft tissue sarcomas. And the squamous cell cancer of head and neck like Fanconi anemia is the one that is associated with disc keratosis congenita. There is no solid organ tumors that are associated with Shwachman-Diamond syndrome. Very important. And the diagnosis is again gene testing only. So if they ask you how to make a diagnosis is by quantifying this RPS19 protein and other RPS sequencing. That's what you're going to do. So here you are going to test for the SBDS gene testing. That's a gold standard for diagnosis. Here you can go for buccal swab. Why you do buccal swab is to go for telomere length analysis. Telomere length analysis. By buccal swab, you can take the cell and analyze for the telomere length. At the same time, you can look for directly this DKC and TURK1 mutational analysis. DKC and TURK mutational analysis. All these things you can do. This is how you make a diagnosis. Majority of them will be treated by allogenic hematopoietic stem cell transplant. Apart from that, they cannot be treated. So three things very important. What are three things we have discussed? One is the Diamond-Blackfan anemia, then is Shwachman-Diamond syndrome, and third one is disc keratosis congenita. All of them are ribosomopathies, and due to problems in the ribosomal proteins, I told you differences between each of them and what cell line they are typically affecting in the bone marrow, even though they are coming under bone marrow failure. Particularly your diamond blackfan will produce anemia, predominantly neutropenia in case of Schwackman diamond, and anemia and thrombocytopenia in case of discoitus congenita. And the physical abnormalities also will vary, and the hematological cancers they produce also will vary. At the same time, the solid organ tumors they produce also will vary. The only congenital bone marrow condition that does not relate to any solid organ tumor is Schwackman diamond syndrome. That's all, SDS. Apart from that, there is another entity that you also have to remember, that is called pure red cell aplasia. Pure red cell aplasia. So what you are going to get in pure red cell aplasia, what are the etiologies? That's what is very important. Etiologies of pure red cell aplasia, there are three things are there. One is called acute, and second one is chronic. In the chronic, it could be either congenital or it could be acquired. Acute causes generally tends to be transient. It will not be persistent at all. Usually it is transient. Transient acute causes usually typically due to parvovirus B19. Parvovirus B19. If they ask you why parvovirus causes, because they affect one important antigen. They infect the RBCs through P antigen. There is something called P antigen in the RBC. They infect the RBC by attaching themselves to an antigen called P antigen on the surface of the RBC. This is a very important question. And destroy the RBC. That is how they cause this red cell aplasia. Especially this parvovirus B19 related pure red cell aplasia is very significant in patients with hereditary spherocytosis and other hemoglobinopathies, especially sickle cell disease. Hereditary spherocytosis and sickle cell disease, where this parvovirus B19 related this pure red cell aplasia is very, very, very important and significant also. And next thing, some drugs are also related. For example, with azathioprine, Septron, cotrimoxazole, all these things are associated with acute transient pure red cell aplasia. Very important in this group is the parvovirus B19. That's it. So congenital and chronic, only one cause that is very important is something called diamond blackfan anemia. We already discussed DBA, diamond blackfan syndrome or diamond blackfan anemia. Chronic and acquired causes, typically it is idiopathic, very common, or it can be associated with thymoma, again very important cause. For exams, thymoma associated with pure red cell aplasia, multiple times asked question. Or it can be associated with SLE, rheumatoid arthritis and other autoimmune features. It can be associated with lymphomas, CLL, then it can be associated with myelodysplastic syndrome, viral infection, lot of drugs, lot of things can produce chronic acquired pure red cell aplasia. But very important in this group, if you ask me, answer will be parvovirus B19, especially in those who are affected with hereditary spherocytosis or hemoglobinopathies, and diamond blackfan anemia and thymoma. These are three things where your money is in exam, very, very commonly asked in exam. And again, parvovirus enters RBC, infects RBC through what antigen? If they ask you, again answer must be P antigen. Very important, all these things. Then treatment wise, if they ask you, depending on the cause. For example, you can go for thymectomy. If you have a thymoma or if thymoma is enlarged, you can use something called thymectomy, or you can use IVIG. Indications for intravenous immunoglobulin, if the patient is having infection with parvovirus plus patient is also immunosuppressed. In this patients you can use IVIG also. Then you can go for immunosuppression or chemotherapy, provided if the patient is having CLL or if it's a idiopathic pure red cell aplasia. In both this condition, immunosuppression really works. And you can go for allogenic, finally, stem cell hematopoietic stem cell transplant. And supportive transfusions you can do. If there's severe anemia, you are going to transfuse anyway. And if the patient is having erythropoietin less than 500, as usual, you are going to add erythroid stimulating agents also, ESAs also. But apart from that, that's a standard thing. But thymectomy, IVIG, immunosuppression, allogenic stem cell transplant. If they ask you, best treatment will be allogenic stem cell transplant. Thymectomy is indicated only if the thymus is enlarged in CT scan of the chest. Apart from that, you don't do a thymectomy in these patients. Finally, let us discuss on the etiologies of a pancytopenia. This is the final thing that I'm going to discuss in the anemia section. So that is etiologies of the pancytopenia. Whenever pancytopenia, you can go for reduced marrow, pancytopenia with reduced marrow cellularity, pancytopenia with the increased marrow cellularity, or a hypercellular marrow, or a cellular marrow with pancytopenia. Or third thing, you can get with replacement of the marrow, that is what we call myelophthisis, marrow replacement with some other substance. And the fourth one you can see in systemic diseases. You can see pancytopenia. Pancytopenia with low cellularity, hypocellular marrow, you will typically see in aplastic anemia. That's a classic cause. Hypocellularity, pancytopenia in the hypocellular marrow, typically aplastic anemia, or you can see in a patient with hypoplastic MDS, or you can see in paroxysmal nocturnal hemoglobinuria with aplastic anemia overlap. So in these conditions you can see hypocellular marrow, hypoplastic MDS or PNS associated with an aplastic anemia. You can see hypocellular marrow. Whenever you have pancytopenia with increased cellularity, the most important exam they will expect is the PNH. Typically the classic PNH will have cellular marrow only. Only the PNH associated with aplastic anemia or aplastic anemia causing PNH clone, in those conditions you will have a hypocellular marrow. Apart from that, in a classic PNH you will get a hypercellular or a cellular marrow only. Then you can get with the myelodysplastic syndrome. Typically I told you, except in hypoplastic MDS, in many of the MDS the marrow will be hypercellular. Sometime back only I described. And next thing you have something called leukemic leukemia, where the blasts will be only in the marrow, they will not be released into the circulation in the first place. So this is called leukemic leukemia. And next is here something called severe megaloblastic anemia. Severe megaloblastic anemia. Marrow replacement with some other tissue. For example, it can happen in myelofibrosis. It can happen with bone marrow infiltration, typically with granulomatous infiltration of the bone marrow like sarcoid, TB, and all these things. Granulomatous infiltration of the marrow, or you can result in some metastasis, especially solid organ tumor metastasis. You might result in a pancytopenia, but these are not that important. Systemic diseases causing pancytopenia, the most important will be hypersplenism. Hypersplenism. Apart from that, you might result in pancytopenia and sepsis, because it causes DEC also. Alcohol and a lot of toxin related things can also produce pancytopenia. But apart from this, what is very important? Hypocellular marrow with pancytopenia, exam, hit on your head, aplastic anemia. Hypercellular marrow with pancytopenia, exam, typically hit on your head, PNH, and second one is MDS. Myelophthisis, marrow replacement, myelofibrosis and marrow infiltration, especially with granulomatous infiltration. Systemic diseases causing pancytopenia, answer is hypersplenism, topmost cause. So hypocellular marrow, aplastic anemia, cellular marrow, PNH and MDS, infiltration, marrow infiltration, myelophthisis, that is granulomatous infiltration, or it could be a myelofibrosis, fibrous tissue infiltration. Last one, systemic disease, hypersplenism is the most important. Other things are also important, but not that important for exam. So these are the etiologies of pancytopenia. I think with this we are completing the anemia section. So I think we can move on to the WBC in the next coming sections.